So good afternoon, everybody. Welcome you all to this Friday webinar. All our webinars are supported by HSSC. And today the theme is on, learning from errors and incident reports. And we are going to focus on topic spotting the subtle signs of deterioration to prevent the cardiac arrest. So before getting into the session, I would like to take you all through the quick introduction about 𝐒𝐻-𝐨 for the benefit of the newcomers. So about us, we have been established since the year 2018, and we have been committed to providing comprehensive training program designed to enhance the capabilities of the healthcare professionals. And we have 10,000 plus healthcare professionals have got benefit out of us, and 75 plus hospital have networked with us, and 50 plus course topics have been launched so far. And with this 10,000, with our 𝐒𝐻-𝐨 community members, I welcome you all, the new participants who have come up for this today's webinar to join our WhatsApp community and get benefit out of our program and build confidence and transform your patient care. And 𝐒𝐻-𝐨 learning pyramid. So what it actually speaks about, it has 4 stages. The stage 4 is focusing on the service excellence skills. That is nothing but when a healthcare professional entering into the hospital, so they should have a certain qualities to survive in the healthcare industry. So where, for example, we focus on infection prevention basics, communication, professionalism, and etiquette. So after that, you can be, focus on the stage 2 training, which is actually talking about the core patient care skills. So this will be dealing about the bedside procedural skills. So you would have heard about a term called you are competent in one aspect of procedure. So we 𝐒𝐻-𝐨 focus on the healthcare professional to be competent in all aspects of procedure. So transforming you from the competent as a clinical expert. So once you have become a clinical expert, it is a time you have to look into the stage 3, where it is about the specialization skills. Already you will be in the specialization department, for example, in the labor room or in the emergency department or in ICUs. So, or you can either choose your specialty. So this is the time where you can, focus on your specialty. So this is like, for example, we have ER upskilling program, labor room upskilling program, and also we have infection control nurse course program and the clinical instructor program for you all. And once you have done your specialty, it's the time to march towards the leadership journey. So where you have 2 pathways, one is vertical pathway, another one is lateral pathway. The vertical pathway is nothing but where you are seeing here in your own hospitals, like becoming a senior staff nurse, in charge, supervisor, ANS, DNS, and CN of the hospital. Where in case of lateral pathway, we or you nurses, we all have a capability in resolving all kind of patient complaints or guiding them from the admission till the discharge. So take up a role into the administration and see yourself as a CEO of the hospital. It's not just about the daydreaming to become a CEO of the hospital, where there are a lot of nurses who have achieved this position in many of the states in India. So this is all about the 𝐒𝐻-𝐨 learning pyramid. So I have an announcement. This is about the infection control nurse course, which is collaboratively given by 𝐒𝐻-𝐨 and 𝐾𝐞. It's a self-paced learning. The course highlights are comprehensive, and we have seen many nurses who have completed this course have transformed themselves from the bedside as an infection control nurse. So this is the special offer which is running over. It's on the display. You can see it off. And to know more details about our course, you can contact the number on the display, who is Ms. Jayanti, our admin manager, and also you can visit our website, which is www.skillsformed.com. Yes, so today's topic will be dealt by us. So I am your Stella Townsend. I am the nurse training manager in 𝐒𝐻-𝐨, and we have Dr. Parivallavan Rajavelu, who is a consultant surgeon, visionary founder of 𝐒𝐻-𝐨, and he is like a passionate advocate for the healthcare quality, and he has played a vital key roles in 𝐒𝐫𝐞, like he contributes as a mentor, national speaker, and GC committee member, and he also serves as a chair for EndoSafe, which is endoscopy safety across the Indian healthcare settings. And his leadership is deeply rooted in extensive clinical expertise and ongoing research and also international presentations. Through Skills for Med, he contributes and continues in the healthcare advancements by equipping the healthcare professionals with real world skills and practical knowledge. And Dr. Pari's unique blend of clinical expertise, clinical skills, academic rigor, and the system level of thinking made himself as an inspiration and the change maker in today's healthcare landscape. So welcome you, sir.
Thank you so much, Stella. Thank you.
Yes. So as I've said, many of would have heard a term, no, always we would say like prevention is better than cure. So, but early recognition, really plays a vital role. It's a bridge between the life and the death. So that's how we have taken this topic. So you will have a lot of things and a lot of insights when you come to the end of the session. So, so before getting into, let me launch the poll here. As usual, there are 5 questions. I have launched the poll. So I request all the participants to quickly answer to this poll questions. You have 5 basic questions. You have 3 minutes to go. Thank you so much. You have 2 minutes, 30 seconds left. So you have 1 minute, 30 seconds left. You have 1 more minute left. Thirty seconds left. Yeah, thank you so much. I'm going to end this poll. Thank you for all your participation. So I'm going to share the results here. I invite Dr. Pari to discuss the results, poll results.
Thank you, Stella. I think Again, the first question nowadays is all about Hollywood or Bollywood movies. And you can see that, I am no longer involved in creating these polls. Okay, so I think it's very, very interesting. 10% of the people, have chosen Queen, which means they're not totally unprepared. I think they are the most honest people in this audience. And then the majority, I think, or not, yeah, not the majority. I think the majority are saying all is well. I think this is something which we want to, sort of tell ourselves. We don't want the bad things to happen. So that's the natural response. And no, life won't come again. Is again 24 and ready to fight is 28. So there are varying levels of emotions when you see a person who is suddenly deteriorates. And I think as correctly, I can sort of uh, um, go with the majority emotion saying that first thing we think is, okay, all is going to be well. No, I'm sure I'll take care of it. So that's the majority of the emotion which comes through. The second question is, how often do you encounter patients showing early sepsis? So again, majority have said daily. In an acute hospital, that happens almost on a daily basis. So that's very, very true. And what's the biggest challenge in recognizing deteriorating patients? So here we have put, really very day-to-day barriers. So the majority have told it's heavy workload, which is very, very true. And communication gaps, insufficient knowledge, lack of assessment tools. So all of them are there. But I think in our context, the workload is what really makes it, very, very challenging. So are you familiar with SIRS criteria? Systemic inflammatory response syndrome. I think majority or familiar or somewhat familiar, and about equal number, 50-50, I would say this one. I need a refresher or need to know about SIRS. I think it's good thing that we actually, put this up. Because I feel, in our country, sepsis is the, number one cause of people going into, deteriorating and going into arrest. So this really reflects that. And final question is, when did you last attend a sepsis recognition training? Again, within a year is almost majority of them, more than 70%. That's great to know. That's fantastic. Okay, I think that's a very nice, snapshot of what we go through when there is a deterioration, and also about SIRS and sepsis.
Thank you so much, doctor. So let us begin with the scenario. So here is a patient. So we have an emergency patient named Lakshmi, and she's 65 years of old, who got admitted with the complaints of urinary tract infection. And 2 hours ago, her vitals were so stable, and she was with normal assessment and findings. And now at present, she have got cardiac arrest, and the CPR is in progress. So this is just an outline of the scenario. So our journey to save life. So today your agenda is going to be on the case Mrs. Lakshmi, how this 2 hours of decline have happened, and what is that SIRS criteria, your early warning system, and how to do the root cause analysis, the system failures, how to identify it, and what are all the prevention strategies, to know, like to never miss again. So this is learning from the errors and incident reports, where you will have the future to prevent the future tragedies. So coming to this scenario back, the person behind the incident. So she is the patient, as I have discussed already. She have admitted to ER with this UTI symptom. Initially, at the time of admission, her vitals was heart rate is 95 beats per minute, and BP was 130/80. Respiratory rate is 18, and temperature is 37.8 degrees Celsius. And she's alert, she's oriented, and only thing is she had a mild discomfort. And hour 0, what happened to the patient is, like, in the emergency department, UTI is confirmed, and there was dysuria, and she had a mild fever, and mild tachycardia, which was heart rate was 102, attributed to the infection. And she had a fluid challenge given, so 500 ml normal saline was flushed, and antibiotics was started. She was transferred to the medical ward. So these all things were done in the emergency in the hour 0, and the patient was transformed to the medical ward. So in hour 1, the warning signs got emerged. So heart rate from 109, it was like increased to 118 beats per minute. Mild concern started, and again patient was reporting feeling slightly unwell, and obviously the family was noticing she seems more tired and a bit confused, and nurse documents continues the routine care. So this is what happened in the hour 1. So what happened? Without any delay, the nurse informs to the duty doctor via the phone. Her heart rate at present when she was calling is like 125 heart rate and increased tachycardia, and she had a BP of 110/70, like beginning to drop. So she was admitted with a normal BP, and now it's have begun to drop, and she had an increased respiratory rate, which is 22 breaths per minute. So what doctor have advised over the phone to the nurse was monitor the patient closely and we'll see during the rounds. This was the reply from the doctor. So hour 2, what happened? The system failure complete. So BP crashes to 80/50, heart rate for 140, altered mental status, doctor still in rounds, delayed response, and family calls repeatedly because they are in the panic situation. Something is happening to her, to their family member. So that's what they are into. And the patient ended up in the cardiac arrest, and code blue activated for the patient. So in the emergency situation, it is always you have to count every minute, and you have to act so fast in order to prevent the patient from the deadly situation. So what could have went wrong for this patient, Mrs. Lakshmi? So Dr. Pari, can you please take us through that?
Yeah. So basically, I think this week is about learning from mistakes. I think I hope all of you would have now known about the monthly or weekly rhythm the Skills Format webinar goes through, right? So this particular week is about learning from mistakes, and where we discuss an incident which happened in the hospital and then try to go through a root cause analysis and corrective and preventive action. So we use this opportunity to sort of give some knowledge and also try and give some tips and skills to make sure that these sort of mistakes do not happen in our hospitals. So nobody is immune from this, and all of us have this problem. So that's the reason now we are sharing it with everybody. So we have also discussed about the 5 why analysis. So when you do the root cause analysis, we use the 5 why analysis. You can always go back to our webinar where we discuss about the root cause analysis and 5 why and other methods of analyzing the incidents. But here we're not going to go in detail. So basically, it is a very systematic way of investigating the incidents, and we actually moving from not blaming somebody to understanding why this problem happened, how can we prevent this in the future. And in quality, it is very, very important to understand that the root cause is actually usually a system failure. There will be multiple factors, and there is no single individual or single cause for any particular incident. So we have to look at all of them and focus on system improvement. So that is what, first I thought, we will do that looking at this incident. Next slide. Okay, so let's go through the 5 why analysis. So why did this patient have this cardiac arrest? Because she went into septic shock. So why did the septic shock happen? Because of delayed recognition. And why was it delayed? There was a communication breakdown. So, and why was this communication breakdown happen? If you ask that question, actually there is no policy on or protocol on how to escalate care based on what we find at the bedside. So this is something which is can be easily implemented, but because our care is not standardized. It varies from hospital to hospital. There are some hospitals who would put this escalation protocol in place, give the training, and make people accountable. And there are some hospitals where this doesn't happen. So again, it is not a matter of blaming this or that hospital. So you just look at these incidents and find out what is that we can do. So we will get into the corrective and preventive actions a bit later, but this seems to be the why this happened. I mean, the answer to your question, Stella, is that first is the lack of response to the communication. I wouldn't say it is communication breakdown. It is actually the lack of response to the communication that delayed the whole thing and happened.
Yes.
And this response, probably that doctor was not experienced and and did not attend the training on these sort of things. So there are a lot of other systemic causes which will come up if you dig deeper. But because for lack of time, we'll stop with that.
Doctor, you're there?
Yeah.
Yeah.
You can move to the next.
Yeah. Yes.
Okay. So again, this is another way of looking at the root cause. This is familiarly known as the fishbone analysis. So you put the incident here. Now, cardiac arrest due to sepsis should be in the head of the fish, and you look at the various other causes as in the five-way analysis. We only talk about one particular root cause, but there could be other contributory factors like standardized sepsis protocol, inadequate SIRS criteria awareness, no escalation timeline requirements, and things like that. Okay, next slide.
So,
Can you still explain what are the common causes of code blue activation and what are the common causes of cardiac arrest that we see in hospitals?
yes, doctor. So the common reasons for in-hospital code blue activation would be like, there are various categories. One obvious thing is like if patient has no pulse, no breathe, then cardiac arrest and respiratory arrest, obviously the code blue is activated. And mental status change might be the patient is disoriented, unresponsively, suddenly becoming unresponsive, or mental confusion. This is all a initial sign which is shown by the patient that the patient is going to deteriorate. And patient is having chest pain, might be acute pain. If we are not acting it fast, then the patient will end up in the cardiac arrest because the progressive is very fast when it comes to the acute chest pain. And when it comes to convulsion, syncope, or seizure, then the patient is going to have the brain functions are going to get affected and ending up in the system failure in the heart and the staff consent. So this is like you don't have to wait until the patient get cardiac arrest to alert the code blue. Might be the staff has a concern because she is taking care of the patient. She is feeling something is going wrong with that particular patient. Obviously, she can alert the code blue in order to improve the patient status and to prevent the patient from the serious harm. So when it comes to common causes of cardiac arrest in the hospital, so these are all the various category and causes what we have. So the cardiac causes is like, obviously you all know, it might be acute coronary syndrome, arrhythmias, heart failures, mechanical issues, and inherited conditions. This is all everybody knows. How come the other categories? So, when it comes to cardiac arrest, when the proper oxygen supply is not there to the heart, it's not the circulation is not supported by the body itself, then the cardiac arrest is going to happen. It's not supposed to be the heart itself must be a problem for the cardiac arrest. Might be the supportive organs. For example, here as we have given the respiratory system, when it comes to hypoxemia, low oxygen level or higher carbon dioxide level, imagine automatically the less oxygen supply to the cardiac heart muscles, and it's ending up in the heart muscle failure and the cardiac arrest is going to happen. When it comes to sepsis and shock, No, the patients are like sepsis, hemorrhagic. What happens for the patient? The patient will have the collapsed in the blood pressure readings, obviously ending up in the cardiac arrest. And also patient with a thromboembolic status, whether it is a massive pulmonary embolism or tension pneumothorax. What happens? The patient's heart is not going to beat against the clotting factor or the blocked pathway. The patient heart will not be able to beat against the blocked pathway. And when it comes to metabolic and toxic electrolyte imbalance, whether it is a potassium, calcium, or magnesium, even the acidosis, when the electrolyte imbalance is happening, what actually happens is like for the heart pumping activity, there should be the electrical signal. It's going to disrupt, this imbalance is going to disrupt the electrical activity, which will again disrupt the functioning of the heart, leading to the cardiac arrest. And when it comes to neurologic, already I've discussed, is there might be a stroke, or the seizure. Neurological dysfunction is going to happen. The brain is going to dysfunction, which suppresses the oxygen supply, and patient is going to have the cardiac arrest. And when it comes to perioperative sedation or anesthesia issue or procedural complications, even the post-operative hypoxia, what actually going to happen for the patient? The patient's heart is going to starve for the oxygen, leading to the cardiac arrest. So these are the common causes which is in the hospital. So when it comes to code blue activation and you are in the process of giving the CPR, you have to equally focus on the given these H's and T's. What is it actually? CPR, you are reviving the heart functioning, and equally you have to treat the underlying cause, which will be the betterment treatment. So what is all about, like we are talking about for H's, we are talking about hypovolemia, like you will be like ending up in correcting the patient fluid replacement. Hypoxia, you will focus on the oxygen saturation, either by ventilation or by administering the oxygen. And for the hydrogen ions, or for the hyperkalemia and hyperkalemia, it is all about the the electrolyte imbalance. You will be focusing on correcting the electrolyte imbalance. And when it comes to hypothermia, you will be like covering the patient with a blanket, maintaining the room temperature to the normal room temperature, comforting the patient. And when it comes to hypoglycemia, as per your hospital protocol, you will manage the hyperglycemia situation. For example, you will administer the dextrose. When it comes to T's, these are all the things you have to focus on. They're like toxins or tablets. Obviously, you're going to stop the exposure to the toxins, and you will proceed in administering the antidote. For example, the patient has toxins to opioids, then you will stop the exposure to the opioids and you will administer the naloxone, for example. And when the patient is having a tamponade, so this is a condition where the patient will be undergoing for pericardiocentesis. And when it comes to tension pneumothorax, like you will have, you will insert a needle, you will release the tension, and you will go for the chest, drain insertion. And when it comes to thrombosis, as per your hospital policy, either for the thrombosis and thromboembolism, focusing on, you will liaise the, clot factor, or for the thrombosis, even you will call the cardiologist and you will take the preventive measures. And when it comes to trauma, you will focus on, if the patient is bleeding a lot, you will focus on arresting the bleeding, and even patient may undergo for the minor procedure. So these are all the things which is a reversible cause of cardiac arrest.
Yeah.
If these are like, sorry, doctor?
Yeah, go ahead.
Yeah, if these are focused carefully, and the underlying causes are treated properly, the cardiac arrest can be you can bring back the patient to the normal condition. You can reverse it back.
I think
So
it's very important,
yes,
right? Can you just go back,
yes,
Stella?
doctor. Yeah.
Because the mortality of a CPR is almost 80%. Once the patient has a cardiopulmonary, arrest, and you do a CPR, the mortality is very, very high. And I know I have been witnessing CPR as a head of emergency for almost 10 years. And this is what makes the difference between a patient coming out of a CPR or not. So many, we'll just focus on the ACLS protocol of CPR. Just going through the sort of stepwise thing. But there are some intensivists and some emergency physicians who actually start thinking about how is it a reversible cause? Can I do something to reverse this, cardiac arrest? And this is a fantastic framing which has to go through your mind mentally. All these questions you have to ask and quickly try and see whether you can diagnose it and reverse it. So as you're going through the ACLS protocol, this etiological thinking should also be going through your mind to do that. But today, what we are going to talk about is not how to do the CPR, but I just thought I'll highlight it. But we are here talking about how not to get this patient to this stage, because once the patient gets into this stage, the mortality is 80%. So you don't want to do that. So how do we not prevent the patient from going into this stage is what we're going to discuss about. Yeah, please go ahead.
Yes, yes. Thank you so much, doctor. And as we have discussed this X and T's and all, no, we should have a certain a standard tool to do the early recognition beyond. So now Dr. Pari will be taking us through that.
Yeah, as I told you, the whole aim is to know how to recognize the subtle signs and prevent a patient from getting into cardiac arrest. And I think of late, the most valuable tool we have is known as the next slide, please. So this is the tool which actually in many hospitals has almost brought the code blue activation to 0. So this is known as the modified early warning score, or the Muse chart. Okay, and instead of the standard temperature, pulse and respiratory chart, TPR chart, many hospitals have now implemented this Muse chart. So as you can see, the Muse chart has there are let me get to the pointer. Yeah. So there are the same vitals, the respiratory rate, the saturation, whether the patient is on air or oxygen, BP, pulse, consciousness, and temperature. It's the same as you see in TPR chart, but the difference is that each of these is given an objective scoring, depending upon how much, is it less or more than the normal. As you can see, the center is the normal values, where the score will be 0, right? So, for example, respiratory rate 12 to 20, the score is 0. And for a saturation for a normal patient, it is should be more than 96. And for a patient with the COPD, this will be the value. So like that, you have the normal, and then whenever these things go away from the normal, there are two things. One, a score is given, and also a color coding is given. So this is very easy. If you have a Muse chart, anybody in the red area, your red flag goes up, you will escalate care. And if there are multiple abnormalities and the score is sort of above a certain level, then again the escalation will go. So this is a very objective way. This was introduced initially in the United Kingdom in the NHS hospitals as the National Early Warning Score, NEWS. So then, seeing the success of that, now many other countries are adopted, and even in India, we have many hospitals, including my own, who have implemented this Muse chart, and it really reduces the incidence of, cardiac arrest in hospital cardiac arrest. It has been proven beyond doubt. So any score more than 5, there's an immediate medical review has to be taken. Another thing it does is it empowers the nurses to take decisions on their own. If the score goes above a certain level, the nurses can change their monitoring from second hourly to continuous monitoring, and similarly, so many other actions they can take. So it's a fantastic replacement to the TPR chart, and this is actually made a lot of difference in recognizing the subtle signs of cardiac arrest. Next slide. So we talked about SIRS. So this is the systemic inflammatory response syndrome. This is early recognition of sepsis. And the criteria is a temperature of more than 38, or hypothermia less than 36, heart rate of more than 90 beats per minute, and white cell count more than 12,000, or again less than 4,000, respiratory rate greater than 20. So 2 of these or more are present, then that is a high risk. So as you know, it is something which especially in a patient with infection, like this particular patient we are talking about. So that is why we are focusing on this. So you need to detect the patient when they are actually in this stage. So that's again, these are subtle signs which you need to look at. Next slide, please. So the other thing I wanted to point out is this ACVPU scale. And usually we talk about GCS for level of consciousness, but it's very difficult to remember all the components of GCS. Of course, if you're in a neurology ward, you probably would keep doing it every day and remember. But anybody on the ward or any general ward apart from neurology will find very difficult to remember the GCS, Glasgow Coma Scale. So for them, there is a very simple scale to remember. Alert, is the patient confused? C. V is are they responding to verbal stimuli? P is, are they responding to pain stimuli? Or if they don't respond to anything at all, then they are termed as unresponsive. It very roughly, correlates with the various GCS levels. But what I want to talk today in terms of recognizing cardiac arrest early, the subtle signs is what is known as the new onset of confusion. So C is not just confusion. It is new onset confusion. Now, what is new onset confusion is you would have probably, in this, again, this particular patient is a typical example. 2 hours ago, you would have evaluated the patient. Patient is fully alert conscious. And then after 2 hours, you go for some other rounds to the patient. Patient is not completely unconscious or unconscious, but they have subtle signs like this. No, they're not able to understand where they are. They don't know the time. No, these are very, very subtle things which was not present an hour or two earlier. So this new onset confusion is a very important indicator of deteriorating sepsis. Next slide, please. So there are many things which you could put in your hospital to make sure that you don't recognize the patient after they've gone into the cardiac arrest. So one I already explained to you is the modified early warning score to monitor the vital signs. And the second is a continuous vital sign monitoring and sending data to mobile devices. There are several new innovations which have come. These are things which you sort of plug onto the patient, or it's just like a watch the patient wears, wearables, and through the hospital Wi-Fi, it goes to the nursing desk. So even though a patient may be in a mixed ward, because now we have lack of beds, which is a big problem. So because of lack of beds in the ICU, many patients have to be transferred. Even if they are we would keep them in the ICU if we have beds, but we need more beds for more serious patients. So in a typical ward in an acute care hospital, you might have 2 or 3 patients who are actually just come from the ICU and who needs continuous monitoring, and this really helps. So in a combination of incorporating modified early warning score into these systems and using technology, the nursing desk can have a panel where they keep monitoring all these patients, and there is a assigned nurse who just looks at these data and alerts the doctor immediately. So that is a very good system. It doesn't cost too much. Then institution of rapid response teams or the medical emergency teams. Several hospitals use this because code blue happens after the event. Whereas if you recognize the subtle signs and you think this patient might get into the code blue situation, you activate the MET or the medical emergency team or the rapid response team. So this helps in early recognition and early treatment. And again, as I told you, wearable and new technology is going to the next level with the help of AI and machine learning algorithms. You would have read in the newspapers several reports of patients being detected with usually the Apple Watch is what is very good nowadays. So there are several news items, even in India, where a patient had atrial fibrillation or a heart block, and the watch throws an alert saying it actually diagnoses. That's the whole thing. You have atrial fibrillation. Please go and see the doctor immediately. And these people have no symptoms. They're sitting at the home watching TV. They probably have some palpitation if they have atrial fibrillation. In a heart block, many of them may not have symptoms. So these sort of modern technology is actually helping people, and it is not yet scientifically validated. So don't go and buy that Apple Watch, as soon as you finish this webinar. So wait for the scientific, evidence to come forth. But these are very, useful advances that are coming in the horizon, and maybe in the next 5 years, all of us will be wearing a watch which can diagnose many of these conditions. So I think that these are the ways in which you can actually recognize and prevent a patient from getting into a cardiac arrest. Next slide.
Yes.
You can take
Yes.
over now, Stella. Yeah.
Yes, yes. So your turn. So for all the participants, spot the red flag. So here's the case, Mr. Rajesh, post-op day 1. So heart rate is like from 95, it has shifted to 108, and now it shifted to 118. So the temperature is like at earlier it was like 37.5 degrees Celsius, and now it is 38.2 degrees Celsius. And the behavior is like becomes quiet and less responsive. So these are the 3 things identified from the patient, Mr. Rajesh. So what would you do right now? So I want you all to drop your answer, whether it is option A, B, C, or D, in the chat box.
Before you finish the question, the answer is already
Yes,
given.
yes, that's what I'm saying. I was about to say that. Thank you so much. Yes. Yes, I think everybody would have got it right, because as per the SIRS criteria, like greater than two of the symptoms are like right there, you're going to call the doctor immediately. Okay, one answer is like 2 of them have answered option D. Okay, so the right answer is like call the doctor immediately. So thank you so much for all your response, like you have done. So I have one more question for you all. So that is like, the high risk, how to spot the red flag here. How can we recognize a patient developing SARS in order to prevent progression to sepsis? Actually, in the previous slide, I have let out the small, I have leaked the answer, I think so, doctor, in the previous slide. Okay. Anyway, like how you will recognize a patient developing SARS in order to prevent progression. You can drop your answers in the chat box. Yes.
You should have probably given a different, made it C or D, because it's all
Yes.
B. So we don't know it's for this question or previous question.
Yes, yes. I could have done that. I'll work on that. Is it B? Yes, yes. Okay, C. Okay. Some are saying like C, and most of them have answered B.
Yeah, majority are saying
Yeah.
it's
Yes, yes.
identifying more than 2 SIRS criteria early.
Criteria early. So thank you so much. So anyway, thank you so much. So the right answer, as most of them have identified, by identifying no greater than or equal to 2 SARS criteria early. So this is how you're going to recognize a patient developing SARS. So now Dr. Pari is going to take us through like SARS versus sepsis, and like versus septic shock. It's all yours, doctor.
Yeah, now there is, as Stella pointed out, there are several causes for cardiac arrest. So again, because of limited time, and we chose one patient incident, and we are trying to find out, learn more about it, so that we are knowledgeable to prevent this in the future. So for this, we need to understand in terms of sepsis. The patient in this particular incident is the patient who had a urinary tract infection and then went into cardiac arrest. So if you need to identify it early, you need to understand this concept, that what is SIRS, what is sepsis, and what is septic shock. Next slide, please. So yeah, next slide. So you need to understand that it is a spectrum. So the infection, SIRS is actually only an inflammation. it could be need not be due to infection. Even, an autoimmune disease or any, it happened in COVID, isn't it? Many people in COVID actually didn't die of the infection. They died because of the body's reaction to a new foreign infection. That was a systemic inflammatory response syndrome, which was totally out of control. And that is why the mortality in the COVID pandemic was so high. So it is inflammation plus two abnormal signs. We already spoke about it. No, the SIRS, more than two abnormal signs, is due to inflammation. It could be due to the infection or it need not be. But you need to be alert. Okay, there are two things. Let me rule out whether there's infection, especially with the history and clinical findings. You can actually have a very good guess it is because of infection. If you don't recognize and treat it at the level of the SIRS, and as more time goes about, as you can see here, time and severity are locked together in this particular spectrum. The more time, the more severe the condition and more mortality. So when it comes to sepsis, infection is there plus an organ dysfunction. So there is all full-blown SIRS, and there is a proof for infection. That is your white cell count, which goes up. And also there is evidence for organ dysfunction. It could be the kidney, it could be the lung, it could be the brain. That is why I told about consciousness. Now, subtle changes in consciousness is because of the brain dysfunction starting to happen. So infection plus one organ dysfunction, you call it evidence of infection. That is SIRS plus evidence of infection with your white cell count. You cannot wait for culture and sensitivity. It takes 48 hours, right? And other signs of SIRS plus evidence of an organ dysfunction, the patient is in sepsis. And this patient again should be treated aggressively. If you don't do that, then the patient gets into septic shock. So this is what happened to this patient. So persistent low BP and use of vasopressors. If you measure the lactate, it is high. All this is a evidence of poor perfusion. I think Stella explained that very well. That most of the cardiac arrest causes is because of poor perfusion to the tissues and poor perfusion in the cardiac muscle. So this is the whole thing, and there is a high mortality risk, and the patient gets into septic shock. So you can't allow them to go into this level. You should detect them, at the level of SIRS, at least in the sepsis level. So if you have this understanding, then you will understand what is the urgency in detecting this in day-to-day clinical situations. Next slide, please. So here is a acronym. You have to suspect the infection source, S, and E is for elevated vital signs, as that is the SIRS criteria. Patient behavior changes I told you about, that is the P. And then you need to have an escalation protocol, that is the system activation protocol. And I is immediate medical attention. The doctors also should respond to it immediately. And then you do serial monitoring, continuous monitoring. So this is, all these things should be in place in our hospitals. So the frontline healthcare givers should be educated to suspect the infection source, should be educated in SIRS to detect the early infection, and also early behavioral changes in the patient. The hospital should put in an escalation protocol for such cases. The doctors should be sensitized and trained to respond immediately. And of course, all the equipment for monitoring should be there. Next slide, please. So this is the explanation of that particular acronym. I already told you: suspicious infection source, elevated vital signs, patient behavior changes, system activation protocol, immediate medical attention within 15 minutes. That's the benchmark. Okay, once you call the doctor, within 15 minutes, the doctor has to be there. And the serial monitoring should be there with the cardiac monitors. Next slide, please. Okay, so there is this concept called sepsis 6 bundle. So when you detect the patient is in sepsis, what are the things you should do? So this is the sepsis 6 protocol. Is a tongue twister, but actually it works very well, and it is approved by the major international and national bodies here. The one thing you have to do is the high flow oxygen. Target is SpO2 more than 94. Second, take blood cultures and so that you seek the infection source. The third is administering empiric IV antibiotics. You don't need to wait for the diagnosis of infection. On the suspicion of infection, start with very high-end antibiotics. So this is something. Antibiotic stewardship is not just not giving antibiotics. It is giving up the antibiotics in the appropriate scenario. Here, this scenario, you need to hit them with very high level of antibiotics. And once the culture comes, you can de-escalate the antibiotics. So that is the third one. Fourth is with the serum lactate and take the additional blood labs for further investigation. The fifth is to start immediate IV resuscitation. And sixth is to give them accurate, measure the urine output accurately and replace the fluids by giving them crystalloids. Okay, all this should have been achieved in the first hour of suspicion of sepsis. So that is known as this sepsis 6 bundle. So if this is done, again, several studies have shown that you don't push them to the septic shock level and therefore reduce the morbidity and mortality for patients. Next slide. So there are you need to look at system-wide safety nets. So I already discussed about the SIRS and recognizing the other red flags, modified early warning score, rapid response teams, med teams, and putting in the protocols when in terms of sepsis, the sepsis 6 protocol. All these are systemic factors. So when you look at the root cause analysis and go into corrective and preventive actions, take these into consideration. Don't just blame the doctor who failed to respond, right? So that is, blaming game. So you need to know that doctor also needs training. That's only part of the process, right? So you need to put all the system spaces in when you get into the corrective and preventive action. So SIRS is like a smoke alarm for infection, and modified early warning score is like a fire alarm for the whole hospital, right? I think next slide. Yeah, I think Stella, you can do the, now that you explained all about it, it becomes easy to go into the corrective and preventive action. Can you please explain?
Yes, yes. Yes, thank you, doctor. So far, like I think you all remember patient Lakshmi. So doctor was discussing like how to identify, the factors. Like he explained about SIRS, about the septic shock, and also about the sepsis. And you all would have now have a clear understanding about like how to recognize and identify the subtle deterioration in the patient. So now we are ready to do the corrective action and preventive action for this patient Lakshmi. How we can prevent the future from such kind of incident. So before getting into the kappa, I have one announcement. So here's the QR code. So since last 2 weeks, we have been started to giving the handouts to our webinar participants, because many are asking a lot of reference material resources related to the webinar. So that's why we have started to work on that. So this is the QR code. You can scan this and then you can purchase this handout resource. So this is related to that. Not only the points discussed in the webinar, it is like additional things where you have clickable links in the PDF. You can go into the resources where I have a clear explanation like what will be there in the handout resource. I'll give you a quick introduction about that handout resource. You will have the prevention strategies, you will have cardiac arrest reduction, what are all the things, and then quality metrics, and you have a few case scenarios where you can actually work on that, and sepsis guidelines, and you have latest guidelines. For these all certain things, you have clickable links where you can click and then you can go to the page and you can spend some time to read that recent guidelines and to update yourself and the implementation strategy. So these are all the entire things which is involved in this handout. So you can get benefit out of this resources. Soon after this webinar, if you going through this handout, you will have a complete knowledge on the spotting the subtle signs of deterioration, and you will be first person who will be preventing the patient from the cardiac arrest. Like you will have more insights and knowledge related to that. So again, who have failed to scan the QR code, now you will have an opportunity to scan it at the end of the session. I will display it there. So okay, coming to the corrective action, call the doctor immediately. That is the first action what you are supposed to do when you see, two SIRS criteria. Like for example, heart rate more than 90 for this patient, and temperature was, a bit above the greater than 38 degrees Celsius. It was there for the patient Lakshmi, and she had a behavioral change. Remember, patient was complaining that she feel unfair, like unwell, and also family is saying she's feeling confused or like that. So you remember the case scenario, right? And you have to follow during the corrective action sepsis 6 bundle approach, which was just discussed by Dr. Pari. And early intervention prevents the deterioration. So if you do all these following things, you can prevent the patient from the deterioration. And for the communication protocol, where we were having a session last Friday. I think you all will remember, like previous webinar participants will know, we were discussing about the SBAR communication structure. So for such patients, when you call for this patient, Mrs. Lakshmi, probably you should say her, like in the situation, you should say her timeline of her vital parameter change, how her temperature was initially and how it changed, and her blood pressure, heart rate, respiratory rate, and also about her current situation, about her mental status. And in the background, you will say about she have come with the UTI, and you will talk about all the assessments you have done for the patient, including the SIRS criteria. You can talk about there to the doctor, and about your mu score in the assessment for this patient. And you will know for the recommendation, of course, you will call the doctor immediately to come and visit patient Lakshmi. So this is how you're going to talk to the doctor with using the SBAR structure. So we are not going to see more things about SBAR because we had a detailed session last week, which is dealt by me and Dr. Nitya Pari. And when it comes to crisis, you have to do direct phone contact, don't do messaging and all. And escalation timeline, which is explained by the doctor, it's a 15 minutes escalation timeline. And prevention strategy, building the failure proof system. So it is like proactive identification protocol. For example, you should have a system wise change. For example, you can implement the Muse chart in your organization if you are not following it up, and you can follow the SIRS criteria, escalation protocol. So such kind of changes and revising the protocol in your organization will help it out. And secondly, it is about technology enhanced monitoring. So doctor was talking about the smart watches and the smart digital system which is coming up, gives a wherever you are, even you are at home, you can get alert about the patient and getting to know the patient is deteriorating and act fast for the patient. And third thing is about team-based approach implementation. When it comes to emergency or when it comes to crisis situation, it's not about the individual care, it is about the teamwork. So where you will have team with different delegation of work, where they will be carrying out when the time of crisis happens for the patient. So this is about the third prevention strategy. Fourth is about continuous quality improvement. So whenever the code blue announced and you have settled down with that, you have to plan a day, discuss about the code blue, what happened, what went wrong, and what all things went on good. And also you can identify the near misses, what all happened. It is all about discussing this in the quality aspect. It is learning from the incidents. So this continuous quality improvement also will be the important factor under the prevention strategies. So we have come to an end. The SIRS criteria, 2+ signs is equal to high risk. You had a clear explanation about SIRS criteria, and you had an learning towards a sepsis 6 bundle approach, and third thing about the importance of maintaining the SBAR structure mandatory, and more on about a lot of things your doctor was dealing about, and also we were discussing about common causes for the cardiac arrest, and mainly the cardiac arrest. Behind the cardiac arrest, the underlying cause will not always be the organ. Heart itself can be the supporting organs also. So this is a key takeaway. So we have, come to an end. One announcement before doing this is like, stay till the end. As I have mentioned already in the group, why I am asking you to stay till the end. We have a winner announcement for the certificate submission, and also I request all the participants to stay till the end, because you will have the feedback link at the end of the session. When you fill the feedback form only, you will be getting the certificate. It is not just only attending to the webinar. So stay till the end, so that you will fill the form to get the certificate. So this is a next week announcement. So the topic will be, the theme is on inspiration and insights from nursing leaders. So still the guest speaker is on the surprise mode. We'll be announcing
I
it
don't
sooner.
think let's reveal the surprise. I think
Reveal this.
people will be
Okay.
happy to come when you tell them who is going to come.
Okay. So Grace Mathai
Gracie
madam is
Mathai,
coming.
madam.
Gracie Mathai madam is coming. If I'm not wrong, doctor, she's the CEO of
No,
Baby
no
Memorial
longer.
Hospital.
I mean, she
Sorry.
was the CEO of
Okay.
Baby Memorial. Yeah.
Okay. So she's a great leader. As you know, she is in one of the greatest example for our stage for what I was talking about, the lateral growth. She's the CEO of the hospital where she was working previously, and so excited to. I am also equally excited to watch her webinar. So everybody, like, I invite all the webinar participants to take part in next week webinar session. So community engagement activity. So this time we had a community engagement activity. This is first time we are doing in skills format. So because we thought to make our webinar participant feel proud and glad and equally valued. No, so that is why. So what was the activity? So you all would have known, I have asked for the, I have given the deadline of 24 hours, and I have asked for the certificate submission, so that, we will announce the winner. So who is
I
that
think
winner?
it's
It's
a little
like,
bit clearer.
she is Shiba Binu, Deputy Nursing Superintendent, Bharat Medical College and Hospital. She is not only a deputy nursing superintendent, she is also holding a post of infection control preventionist and also a quality role. So she is doing not a dual role, she's doing a triple role in that hospital. So Shiba, we are so glad, and so happy that you have attended maximum of our webinar. And also I would like to you can unmute yourself and you can share your thoughts on skills format webinars. Shiba? Miss Shiba? Ma'am, you're there? Jay, she have joined in panelist link, right?
Yes.
Yeah. Shiba ma'am, you can unmute yourself and then you can share a few words as we know. We are not able to hear anything. Jay, can you please check whether Shiba Binu is like
No, her audio is on, but
you're not able to hear here. Yes. Ma'am, we could see you have unmute yourself and your videos are on, but we are not able to hear or see you. So can we proceed to the future slides so that she can correct it off? No, at the back end, Jay also will work on her, directly calling her
That
and
is
sorting
now
it out.
proceed, Stella. Yeah.
Yes, that's what. Thank you so much. Jay, please call her and check out like what is the problem
What
happening
we can
and
do
try
is
to
even to
sort it out.
record, what she's going to say, and we can put it in the next webinar if it's not possible. This webinar.
Yes. Sure, doctor. Yeah.
I think really we have to congratulate the commitment of Shiba, who's attended 24 of our webinars.
Yes.
It's really fantastic.
Yes.
Yeah.
So for Sheba, like what is the price amount already I've announced at the end of the webinar? No, we'll be sending her Amazon voucher of worth rupees 500, and also other achievers we would like to highlight. No, celebrating our learning stars. They are like Miss Rinju Francis. She have obtained 16 certificates, and Miss Usha Rani, who have obtained 13 certificates, and we have Miss Nisha Rajput with 12 certificates. We also congratulate you three of us who have had a continuous dedication and hunger towards the continuous learning. Thank you so much, you all of three. And we are open for question and answer.
I think she's audible now.
Am I audible now?
Yes, yeah.
Yes.
Stella, you can go back to that slide.
No, that's okay.
Thanks, Thank you, sir.
You can probably stop sharing Stella, so that she can.
Yeah.
Again, no, it's not.
Am I audible?
Yes, ma'am, you're audible, but I think you are facing some network issue over there.
Yeah. I think it deserves that. She deserves that to have a clear thing of what she wants to say.
Yes.
But we're not able to hear you, and again, congratulations to you. Thank you for showing so much of support, but we're unable to hear you properly. We want you, to hear what you're saying. So I think Jayanti will, so have coordinate with you, and we will do a good recording of what you want to say and put in the next webinar. Okay? Thank you so much. Thank you.
Thank you, sir.
Thank you so much. Thank you so much, ma'am. Thank you so much for your time.
Thank you for your support again. Thank you.
Yes.
Thank you, sir. Thank you, ma'am.
Thank you.
So I'm going to share the screen, and we are open for Q&A session.
I think there are a few questions in.
Yes. So meanwhile, I equally wanted to project our 2 QR codes, which I was announcing earlier. This is the first QR. You can easily see it's for handout resource, and second one to join our WhatsApp community. All the newcomers who are yet to join our WhatsApp community can scan this QR code and you can join our WhatsApp group. So let me take up the questions. So there is one question. It's about is this a news or Muse scoring relevant in neurological setup?
No. No, this is for the GCS, the Glasgow Coma Scale is the gold standard. So no, that is for neurological, especially neurological patient, you still have to use that. This is for acute care hospitals. There is one particular thing about the level of consciousness using the ACVPU scale. So, if your staff are unable to remember the GCS, you can use it, but I would not say that it is a replacement for Glasgow Coma Scale.
Yes. Thank you, doctor. And also during this time, the feedback form is have been put up in the chat box. You can click the form and you can fill the form. So I am in Q&A portal. That's the only one question was there, doctor. I am into the chat box. There is
Yes.
one question. Do you offer critical care nursing course via online?
We are working on it.
Yeah, we are
Probably,
working on it.
it'll be live in maybe couple of months.
Yeah.
Everybody's happy to see
Great to have Gracie ma'am.
Gracie ma'am is
Yes.
coming next week. There was one question in the beginning.
Yeah, just pulling it up. Sorry to interrupt in between this Q&A portal, doctor. I just want to answer to Ms. Priyanka Sharma. 99 rupees is not for the certificate. 99 rupees is for the handout resource.
Yeah, I think we need to
It's not a
clarify that.
confusion. Yeah,
I think
yeah.
no, it's very important to clarify that no, we don't charge for the certificates.
Yes.
This is optional. No, if you are interested,
Yes.
resource because there's a lot of effort and resources we have to put in to develop this resource. So that's the reason it is being charged. But certificate will remain free as usual. And I think we have to thank Pramod for his appreciation about the session.
Thank you so much, sir. So I'm not able to pull up the question from the chat box.
It's about there was a couple of questions. I think before you ask those questions. Yeah, indication.
Indication. Oh, okay.
Yeah, rapid response team. The indication is almost it's you can decide based on your hospital policy. It's the same as we pointed out. No, the SIRS signs. You could talk about vital signs, respiratory rate below this level or above this level. You know what, or the Muse score. Because Muse takes everything into consideration instead of specific saying that respiratory is so much, heart rate so much, level of consciousness so much. You can include the Muse score. But if you're not doing Muse monitoring, then you need to have individual parameters for the vital parameters, level of consciousness, and same as I put for the causes for code blue. Staff concerns, as Stella pointed out. If the staff is worried about a patient, they can call the RRT team. So you can actually sit with your consultants and put criteria for activation of the rapid response team.
Yes. And another one is like I think septic shock. Before
we
even we
explained
were
that.
dealing about, they have put up this. I think so. It has been
Before
explained.
that. It was before.
Yeah. So it has been explained very clearly. So this is the two things, doctor, you were talking about. The RRT and this.
Yeah, that was what I was talking.
Okay.
Thank you.
So yes.
Raj, for your appreciation about the session, and all the best to you in Ireland.
Okay. He's sharing his personal experience.
You can talk.
Pramod Silva, he's a dialysis nursing officer from Sri Lanka. He's so glad. Okay. Thank you so much.
Yeah, we will keep in touch.
Pramod, sir.
Thank you.
Yes. Thank you so much. Okay. Thank you so much, sir. It is equally, I have also obtained a lot of insights out of this session while preparation and while delivering it.
We learn as we teach.
Yes, so we have still time because we are projecting this, doctor, and also there are number of participants here still who are filling up the feedback form. So we'll be here. The Zoom will be on still they complete it off. Thank you so much, doctor.
Thank you so much to everyone. I'm really glad that so many of you are here and listening to this, and that is what makes us really inspired. So thank you so much. We'll meet next week. Thank you.
Thank you. Miss Manjula Vishwanathan, ma'am, you can scan this QR code to join our WhatsApp group. It would be easy. So if it's not possible, just let us know. Like we will add you in the group also. No problem. And many of them have asked for how to join our WhatsApp group. In the Q&A also, I have seen a couple of people asking us like, just join this QR code which is here, and then you can join in our WhatsApp group.